Hello, good evening to everyone. Thank you for joining me wherever you are in the world. I'm Dr. Philip McMillan, and I have been focused on COVID, long COVID, post COVID, COVID storm, anything about this disease to try and find solutions. And in that time, I have spoken to so many researchers across the world, innovative ideas, and this is just part of that journey. In that, these researchers, Dr. Beate Jager and Joachim Gerlach, have published another paper looking at microclotting. And so we're going to be discussing the science around it and trying to get to the answers as to what is happening. Wherever you are, share it. I'll always try and share that. If you have any very specific scientific questions about what they're talking about, you can put it in the chat. I will try and get to it as well, but we will just be looking at the science. I will mention for the first time here that I am in the process of trying to develop what I call a CPD, Continued Professional Development course, with regards to COVID. And a lot of it is based around some of my research, what other people have done, because I think that we need to get doctors and clinicians together so that we can discuss all of the aspects of it. If you are interested, click on it. I would love for your input as to what you think and whether or not you think it's valuable. This is the plan for the future. So without further ado, let's bring into the stage Beate and Joachim, and let's just ask them to do a quick introduction of themselves. I'll start with you, Beate, and then Joachim. So let us know a little bit about yourself, not too long, and so the audience can know who you are. Beate? Can you hear? All right, you want to go first, Joachim?
I can go first while maybe Beate is still struggling with the audio. Yeah, my name is Joachim Gerlach. Hello, Philip. Good afternoon, good evening, everybody. I'm an entrepreneur, and I was kind of retired after starting my business 15 years ago. And I got into environmental science, medical science, and biology because that is something I really am interested in. And my skills are actually understanding very, very complex systems and to develop solutions in improving whatever system or patient, it doesn't really matter. And so I've been working since day one, even long before the pandemic was declared. I started working on January 15th, 2020, and it has been 6.5 years of uninterrupted 7 days a week, full on research, working in laboratories with colleagues like Philip and many others in the Rapid Research Alliance for Post-Infectious Disease, like a 30-member group of extraordinary scientists and doctors around the world. And we are doing everything we can to help improving diagnostics and treatment for people affected.
Excellent. Thank you very much, Joachim. And Beate, can you have a few words yourself?
I cannot hear you.
Oh, dear. I tell you what, jump out and jump back in.
I cannot hear you.
Okay.
Go out and come back in. I'll give her a call very quickly on the phone. 1 second.
Yeah, so what we'll say is that essentially that I'll just make sure that
Can
Beate,
you hear me?
we can hear you. We can hear you.
I cannot hear you.
Okay. And we'll just ask her. I'll send them a message. Okay, give her a call and we'll see.
Dein Anruf wurde an Voicemail weit.
Okay, she's getting on the phone, so we might as well just start.
Yeah, we'll get on with that. So as we can see here, these are two experts who have been looking at COVID, post-COVID pathology for some time, and we're going to get Beate to jump out and jump back in.
Yeah. Okay.
Yeah, we're going to get her to jump out and jump back in, and then we will get some input from her because she has some very important research with regards to what she has seen. I think it's important, Joachim, is while we're waiting for her to come, is just to highlight the fact that this paper is really the driver in terms of you guys have just put this out for peer review. So it has not yet been peer reviewed, has it?
Yeah, we have Beate, myself, and the whole group that you see there, which is all members of RAPID. We have been publishing since December, like in the last 6 months, we published, I think, 8 papers, and they usually go out as a preprint just to secure and make sure that it gets out there, because peer review can take time, so that we kind of secure the date of the publication, that we get and get as early as possible the information out, because at least 4 of these papers were absolute landmark papers that need to be read and understood by the people in this industry for sure. And so this one here is more about the damage to the microvasculature and the capillaries. And it was triggered by a Substack that I received from Walter Chestnut, who's a pretty good scientist and researcher. And so he talked about that, and I thought, okay, that is really something we've been sitting in front of that for years without realizing that if you have microthrombi blocking the capillaries, you, of course, will not only have a hypoxia state in your tissues, but you might as well lose their tissues. And if it's within the myocardium or within the brain or other very, let's say, irreplaceable cell structures, that might be a big problem. So that is the reason why we are pushing this ahead. And I'm happy that Beate is here today, because she is very, very deep in that topic. Can you hear us now?
Beate, can you hear us now?
Yes, now I can hear you perfectly.
Okay.
Thank you.
Wonderful.
Okay.
So just give a quick introduction to the audience about you.
Well, you know, I spent my life on treating high-risk cardiology patients with clotting disorders, lipid disorders, and I had the privilege to study in Essen, which had a collaboration with University of Wuhan. And I was, when it started, very worried about my friends from China. And so I digged into the research, and yeah, and this occupies now all my time.
Excellent. And so, in effect, you were quite early in terms of getting into the research around COVID. When was the first time that you recognized that people were having persistent symptoms after infection? At what point was that flag that you thought this is not right?
You know, I was at that time working in my lipid center in Mülheim, and I have followed the research available from the very beginning. But one hallmark study was done by Professor Varga from Zurich, pathologist. And she was the one who described the pattern of acute COVID as generalized endotheliitis. And as we were using, this was in March 2020. And I knew also from my laboratory work that there were patients fighting for their lives on intensive care units, because I was that time still working for a big lab, which also looked for patients from University Clinic Aachen and Essen.
Okay,
and so it was clear for me how the pathway should go.
I'm going to say something, and I just wanted to get Joachim's thought before we go into the microclotting. One of the things I usually say is I differentiate post-COVID pathology, which is organ damage like heart, lung, kidney damage, from what I call post-COVID pathology, where the person has had very mild infection but ends up with persistent long-term symptoms. And I think that differentiating the pattern with regards to those two is very important. Any thoughts on that, Joachim?
We are another publication has just come out, and it is actually classifying the general population and, let's say, parts of the general population into a 5-tier severity system, like a triage system. So you can go anywhere from being spike positive, asymptomatic, without any visible or yet measurable disease developments, through various stages, all the way to the patients that arrive at Beate's clinic in a wheelchair. Now, so it's not a two-tier, it's a 5-tier or more differentiated system, because you have to see it is not always the same body regions that are involved, and a lot of the damages are, as the one we see today, are happening in a clandestine, under the radar fashion. And it's very difficult, especially what we talk about today, to measure that with normal biomarkers. A normal cardiologist or a normal medical practitioner would not notice that at all, maybe. Yeah. And so it is much more complex. That's the problem. And that makes it so difficult for us to communicate, because the people that are out in social media and on stage and that are very successful are the ones that just mention one or two things, very narrow, and everything is a nail and they have the sledgehammer. It's one of the most complex multisystemic diseases in medical history. So that we're confronted with. So there is not one silver bullet, and also the patients are not looking all the same. It's a complete different picture, like I said, in different stages.
Yeah, to be frank with you, when I had done my paper, I created what I called 4 different phenotypes: neurological, brain, vagus, vascular, and gut. And actually, when I looked back at it afterwards, I could have built about 7 phenotypes, but I thought that would have been too complicated. And so breaking it down into the major ones made sense. But you're so right. So many people overlap that they don't fit a neat pattern. It really is difficult to make sense of it. So, Beata, when you start to think now, as we come into this question with regards to the microclotting, when did you start to realize that something like apheresis, which I think you'll show us in your slides, was going to be relevant in terms of this kind of problem?
I sent my paper already in March 2020 to our most important institutions. And then I got no answer. Then I published it in German Ärzteblatt in June 2020. So I had worked 30 years before with HELP apheresis, so it was clear from the publications. But you have to know that it is a multi-target treatment. And when we saw in the beginning, these lung failures of patients, it shares in common a lot with treating septic conditions. And we had been treating septic conditions with HELP apheresis already in the 90s of the past century. And I had been using it for EHEC, so in people who had kidney failure and were in coma, and I put them out of coma. So, there is a long research tradition about what this special HELP apheresis we use for 40 years in Germany does about the microvasculature system on different levels, not only by removing viruses, toxins, cytokines, but also by de-escalating the entire clotting system. And then, I was I had this parallel clinical impression. My lipid center in 2020 was full with sky-high risk heart patients. So I was in trouble. I could not invite acute COVID cases into my clinic. I would have killed the heart patients. So I tried to get on an intensive care unit with my machine, but nobody let me do that. So I started treatment of long COVID, or PASCO, how you call it. I started it in my office with the children of my heart sick people. This was in February 21. And then when I had treated the 7th patient or so, who, a young girl from Mülheim, no, young woman, 30 years old, she appeared with a massive Parkinson long COVID appearing like syndrome. And I tried to venipuncture her to do the apheresis. And then I found 12 centimeter long clots in her veins. And then I made this public by all kinds of means. And in parallel, I had started, I think, in May 21, the first vaccine damaged children with stroke. So I had a learning curve. And then I had a very kind American patient, Anne McCloskey, who introduced me to her treating doctors in the United States, Amy Prohl and Dr. Ruhoy and many others. And they talked to me about research that was done in Stellenbosch University in South Africa. So I invited Rezia Pretorius and her team to do the first study, to look what happens if we apply HELP apheresis when applying for fluorescence microscopy. And I talked before already to Jaco Laubscher, who had made similar observations like me, which reconfirmed me, because I had then started to realize HELP apheresis alone cannot do the job. We need additionally aspirin, heparin, clopidogrel, famotidine, other stuff. And we were coming from both edges. And he told me that time, I remember very well, that he had done lysis treatment of lung failure in his intensive care unit, which I didn't have at that time. And he saw that a quarter of an hour later or half an hour later, the milky glass lesions were gone. So it was clear in the early phase of the Delta virus, the clotting was dominant over the inflammation. With chronification, this pattern changed. Yes, and inflammation goes more into autoimmunity, as we see now. And I see now all these mixed pictures where the severely sick patients have almost all G protein coupled antibodies, plus persistent sticky platelet disease, plus endothelial damage. And if you do not manage to hinder capillary erasure, you get terrible clinical outcomes. And this has an ending timeline, and time is working against us, not for us, unfortunately.
Yeah, so I'm curious to hear, Joachim, is that when you were looking at, because I think you guys did some anecdotal, or I don't know if you've published it yet, looking at clotting broadly across cohorts in terms of people who had symptoms, people who didn't have symptoms. What did you find, Joachim?
Yeah, we first of all, Beate and myself, we met in 2021, and it was a very good moment that we both met, and ever since we've been working together very, very closely. And it's good to have such a hero on my side, because there are not many doctors that are so passionate about helping their patients with, and the extracorporeal blood cleansing systems with the HELP apheresis are pretty much the top-notch treatment available globally. I mean, I don't know any other clinic where you can have so much success with that. But it is, of course, the high-end treatment for the patients that are in very, very bad condition. And so Beate and myself, we have been working now over all these years with our other colleagues, Dr. Manan and many other scientists, on trying to understand the full scope of the disease. And the clotting is one big part, probably one of the worst parts next to the spike persistence. I mean, if you look at it, we over all these 6 years, Beate, myself, Manan, we have been dreaming of building a whiteboard and mapping out the complete disease with all with all pathways and so on. But it's humanly not possible, because you would need like a 20-yard long wall and 3 yards high. And if you write very small, you might succeed. I emptied my pool in the house and tried to start there with Post-its. Forget it. But now finally with AI, we have built a closed system and put all our knowledge inside over the past 8 months. And now with iRufus, we have now for the very first time the complete disease with all mechanisms, with over or around 1,000 drug target pathways, several 100,000 opened PDFs cross-tagged in one database that is only specifically done for long COVID, acute COVID, long COVID, and post-vac condition spike protein. So now you can really see it visually. We can visualize it like a galaxy, and you see the start. The antigen comes in, and then from there it branches out. And then you have all the interconnective mechanisms branching out like a huge system, and it looks like a galaxy if you look at it. And now we can say, okay, what happens if we put in such a molecule, or if we do this intervention? You can see already what is shifting. You have the main pathways, the cascades, the triggering, the interactive pathways. So this is amazing. And finally now we can, and that's why we can now publish more papers, because now we're taking all our knowledge from the last 6 years and slowly put it out in papers, because our knowledge has been cannibalized by other people with very severe appropriation, which is not nice. And that is not that is lack of respect to our group, because many people in our group have done groundbreaking work, and we are burning to do this, and we don't do it for fame or money. Yeah.
So when we think about Beata, your presentation, I just wanted you to go through a few of your slides now, just so that people have a context. I'll come back to Joachim afterwards to hear his thoughts on it as well. So just share with us what it is that you are focused on here.
Yes, so diagnostic and treatment options for COVID-19 capillary erasure is our topic today. May I have the next slide? So the major battleground in acute COVID, and also I think still in almost all cases of long COVID, either post-vac or combined cases of long COVID and post-COVID, is the microcirculation. Here is where the spike proteins attack the blood itself, but attack also the surrounding inner protective lining of our vessels in the venous and in the arterial system, but mostly in the capillaries, which is a playground of 7,000 inner square meters. So, and one very typical finding you can see in almost every long COVID severely sick patient is a massive lack in his venous oxygen saturation. Yeah, they have sometimes only 15%, 11%. So you see them, then they have a positive hand grip test, they have blue lips, they have blue feet, they have Renault phenomenon. So I show you, please, next slide. I show you a clinical picture. This was one of my first very early patients I had treated. He was a physically working man from Dortmund, Germany, my hometown. He had lost 30 kilos of weight in 2 months. You see here the atrophy of his muscles. You see he's sitting on a rollator wheelchair. You see his blue feet. You see his muscle atrophy. You see his problems. Yeah, he was unable to walk on his own. And then I looked into his blood and I found something like that, please. The next slide, which was massive, massive platelet activation, clotting. Next slide, massive fibrin, amyloid fibers, endothelial damage, and so on. Next slide. So that's not from this patient, but another patient. In some patients, we could reconstruct structures that are greater than a centimeter. Yeah, in living patients. And so we made this public because, of course, clotting is the end of life. Yes, and may I have the next slide? That's up to date my therapeutic pathway. So what has to happen first? People have to restore their lack of trace elements, vitamins. Then they almost all, if no contraindications, need antiplatelet treatment with aspirin and clopidogrel. They need anticoagulant treatment. I think best is still unfractionated heparin, but you can also take low molecular heparin or apixaban or dabigatran. With the onset of the Omicron, you need to implement antihistaminic treatment, as our friend Chetty was pioneering antihistaminic treatment. For cardiovascular myocarditis, I've seen terribly often, especially in young men, you need ivabradine and beta blockers and in some midodrine. And only if this fails, you need HELP apheresis as top treatment, or alternatively therapeutic plasma exchange, or immune absorption apheresis, or a combination of that. That shall be enough for the moment.
I just want to ask a question here, and it would be interesting to hear Joachim's thought on this, because one of the difficulties from a scientific and a research point of view is that they want very clear protocols. Patient gets this, patient has this, they get this. And I have a suspicion from what I look at in terms of what happens with patients. They are so different that you can never have a specific protocol. How is that going to be managed? Because as I said, because the system would want, they would want you to have a drug that manages long COVID that you do placebo control testing against. I would tell them that will never work. You'll never find anything that works, which is why we are probably where we are now. What are your thoughts on that, Joachim?
Yeah, it starts with the medical science system by itself, as we have mentioned in previous podcast or broadcasts that we did. The compartmentalization of the healthcare system is, of course, a big hurdle. You will not find a single drug. And look, pharmaceuticals are very powerful and very efficient, but they are very narrow. And if you look at a multisystemic disorder like we see here now, depending in which state the patient is in, we are currently juggling around 938 different drug target pathways. So now you can imagine what will happen. So if you want to address only a few, if only 20% of those, it's pharmacologically impossible, because even a cocktail of some pharmaceuticals would cover at the most 20 to 30 pathways, but not 200-300. So it can only be done, maybe we are just discussing that at the moment, how to fit it into the system. So we might say, okay, you do need a regime like Beat is showing with some pharmaceuticals, and as a support, you take natural molecules that we bring now into a bioavailability that is as a supplement at par with pharmaceuticals. We are getting there. And then you can use the supplements as a supplementary support for the pharmacological intervention, and as a whole, we might be able to wave it through. We're discussing that right now with the authorities, but it's really difficult, exactly as you say, because the FDA and EMA regulations on how to go about to get to formalize an intervention that is then accepted as a therapy with a clinical trial, you have to have one or two objectives. So if you say long COVID, I mean, there is no one long COVID. There is stages from, like I described before, from early onset, antigen presence, all the way to almost being dead, sitting there in ME/CFS, autoimmune, in a dark room and screaming all day from pain. So, and anything in between. So I don't know. This will be a very difficult endeavor. Yes, you need AI for that, actually, if you want to do that as a doctor. So you're trying to teach doctors. We see that over the past 3 years we have tried with our groups and our colleagues to train doctors, and this is actually the bottleneck, because it is so complex and it's so difficult. And to teach a normal doctor that doesn't have much experience, Beate could explain that better, what to make of a diagnostic panel and to decide the different treatment options based on the diagnostic panel. It's good now that we have this new database that can machine read all diagnostics and give you at least an idea what's wrong with that patient and which route to go. That is maybe a help to lessen the necessity of too much training for the doctors. You still have to train them, but a lot less.
So I think that because I understand how clinicians think very often, and I'll ask Beata to explain from her context as well, we absolutely detest the conditions like fibromyalgia, ME/CFS, because there was no clear pattern, and they would oftentimes get shunted into functional diagnoses because we didn't have clear protocols, clear treatments, and so on. When you think about how colleagues reflect on the practice of medicine, how in the world would you be able to explain all of this to, say, a group of cardiologists? Can you see a way forward for that, Beata?
Yes, I'm a bit more optimistic. Why? There were hallmark studies published in Circulation showing the rise in myocardial infarction and thromboembolic complications. So it can no longer be ignored. We see excess mortality, especially in the young people. We see more and more handicapped people. So there's an urgent need all over the world, irrespective of what political system, to stop this process, which is the biggest thing on the planet in the moment. And another problem, which of course melts with it, is the rise of wars and distrust, and this is not good. Yeah, we have to stop gain of function research in humans. That has to happen very quickly now.
Yeah, well, you since you've touched on the elephant in the room, I'll throw Joachim under the bus here, which is and so, because I can tell you from a clinical point of view, we are seeing patterns of disease that we have never seen before. It's very difficult for people to understand. One of the worries I have is that the clinical community has largely been silent on this. It's almost as if they're pretending that everything is back to normal. And I'm telling them that no, it is not. And you have a responsibility to say that something is wrong. We don't know what it is, and we need more research. But because of that silence, the public is imagining that we are back to normal. So since Beata brought up this gain of function point, without any controversy, try and handle it sensitively, Joachim. Are we dealing with something that is so far beyond our capability that it needs all the focus and resources across the world to get to the answer to the bottom of this?
No, I don't think so. I mean, as you know from our colleague and our work together with Charles Rixey, and as we have also seen now with Tulsi Gabbard going out of office and leaving a nice last document for humanity, and clearly stating that SARS-CoV-2 is from a lab, and that the gain of function work of Anthony Fauci, Ralph Baric, and Peter Daszak, EcoHealth Alliance, and several other universities funded by the US government and later transferred, because of it was declared illegal in the US, to the Wuhan Institute for Virology, is now on the official US government website. So it's not anymore tinfoil hat conspiracy theory. And fortunately, Beate knows that we started already in February 2020 to look at every piece of gain of function that was inserted into the spike protein into SARS-CoV-2, and everything that you see in the answers of our therapeutic interventions is already incorporated in order to try to tackle and mitigate the exact, for example, furin inhibitors, what can block DC sign, what can be done about the amyloidogenic fibrils that come out, etc., etc. And there's more to, like the super antigen insert. And then there are other ones that came out later, like the bacteriophage behavior and the, let's say, the fibrils that are created and when the spike protein meets neutrophil elastase. So the list is long of what they have incorporated. We have published on that. There are 10 different distinctions between SARS-CoV-2 and all other coronaviruses. And so without even going into any conspiracy theory, this can be measured, this is already documented and should be addressed. And that's what makes this also such a dangerous virus. And what I don't like at the moment on our side of the fence is everybody says it comes from a lab. I don't even mention the word bioweapon, but they say it's a bioweapon, okay. But how can it be a bioweapon? And then they jump right to the vaccine and they say it's a bioweapon, and then they made a vaccine out of it. And that's about the story. And then everybody's upset about the vaccine. And what about the virus?
Yeah.
If it's a
So, yes.
bioweapon, it's a bioweapon. No?
Yeah, so this is the problem that I think that we are facing at the moment. And from a clinical point of view, what I can say, as I tend to look for patterns, and every time I see patients that don't fit in the box, I am looking to see if I can understand how this may be connected to COVID. And what I'm explaining to people is that when I look at patient trajectories, symptom trajectories, very often the viral infection is about 2 to 3 weeks before a severe metabolic or infective, and it appears as though they are not connected. And at the moment, if we don't learn how to trace this back, we are going to go in circles. And this is probably complicating all of the presentations that we are seeing now, is that the timeline, they don't even know they had an infection. They just say, I had some fatigue and some headache. Yeah, I felt a little bit fluey, but then it was gone in a day or two. Not realizing that this can then be relevant to very negative complications down the line. Beata, how do we educate the clinical community and the patient community about this kind of thing?
Philip, I cannot agree more. You know, I make exactly the same observation as you. And we shall keep in mind that, of course, according to your personal genetic condition or pre-diseases like heart diseases or other vessel diseases, of course, you are in a higher risk group. That's one thing. And also some HLA conditions make people relatively unsensitive to get very severe COVID cases. But what I see from a trend is that I still mostly see highly athletic, very, very young patients with worst cases. And it is irrespective of whether they had only long COVID, being unvaccinated, or being both vaccinated and then had COVID, or had COVID first and were then 4 times vaccinated. In the clinical picture, I just have the impression the more they are vaccinated, the harder it's to get them back to their lives.
That's important. Any thoughts on that, Joachim?
Yeah, we have published that also recently. It's called the shadow population of the United States, where we have taken many different data points from insurance companies, work disability in general, infectious disease rising and immune deficiency, etc. So all the databases we could filter from we could see that there is, from the average before 2020 and after 2020, there is a very strong hockey stick rise in many, many conditions. And so it is approximately, we are looking in the US, for example, somewhere between 16 million and 19 million registered long COVID patients that are classified as long COVID, but they are classified mainly just by symptoms assessment. And so let's say the shadow population on top of that could be another 20 to 25 million. So we are looking at the moment at somewhere around 35 million to, or maybe a little bit more people that are directly infected, but through antigen exposure, be it virus and or vaccination, and subsequent development of health disorders. And so the biggest problem is not only the training of doctors, the next one is the distinguishing tools. So if you are a doctor, you're a long COVID expert, but imagine your colleagues at the hospital that you work in. Somebody comes in with hypertension and whatever, fatigue and whatever, they wouldn't even come to the conclusion that it might have something to do with spike protein or COVID, or if they have a stroke or cardiac arrest and things that happen here. So we need to provide the doctors the tool set, diagnostic tool set. At the moment, still ELISA. We're having that already now in Germany, and we are working on it in the US, plus a maybe lateral flow test sets that are specific markers that go across all 6 centers that we have in RAPID. It has to be designed so that you can really tackle the whole multisystemic disease. That means you have 2 horizontals. One is antigenic presence in spike protein that you can measure, EBV or other cofactors. And then the second horizontal is systemic, mitochondria, inflammation, etc. So that what is not organ specific. And under these 2 horizontals, you have 4 verticals: neurodegenerative, cardiovascular, internal, and immunology and autoimmune. And if you structure it that way, and the panel that you test for, you could then very clearly distinguish between a normal chronic illness, diabetes 2 or whatever it is, and a spike protein or COVID-driven disease that you see in front of you as a doctor. Yeah, and that is what we are now trying to roll out with the help of some bigger government agencies.
Excellent. And Beata, I think it's important to explain to the public about the most severe cases and why and how HELP apheresis seems to work for them. What is your experience with that?
Well, maybe can we come back to my slides? Then it's more easy to see. So I propagated this treatment publicly in German Ärzteblatt already in June 2020, but it didn't help. So next slide. HELP apheresis stands for heparin-mediated extracorporeal lipoprotein fibrinogen precipitation, or LDL fibrinogen precipitation. That's the apparatus. Looks a bit complicated, but the key stuff in it is the heparin. Heparin is part of our glycocalyx, of our inner protective layer. But heparin can do more. Let me show you the next slide. Yeah, there in this paper we published in detail the mechanisms of HELP apheresis. We can overjump that here, but heparin, and this was thanks to the publication of Microvascular from England, published in August 2020, it is clear that heparin inhibits the cellular invasion by SARS-CoV-2. And there is a structural dependence of the interaction of the spike S1 receptor binding domain with heparin. Next slide. And this paper was confirmed by Payardi. So heparin acts antiviral, anti-inflammatory, and anti-infective. Next slide. So if you look at what HELP apheresis beneficially does, is It binds covalently spike proteins, but it also binds all other kinds of viral RNA and DNA. It gives a direct access to micro and macro circulation. It lowers fibrinogen by 70%. It lowers the fuel for viral replication, LDL and LPA, also substantially. And it offers in an extracorporeal circuit 400,000 units of unfractionated heparin, which are capable of dissolving microthrombi, and it removes 94% of circulating spike proteins free and bound in exosomes. And we had published already in the 90s and the 2000s how it affects myocardial, cerebral, and pulmonary blood flow beneficially, because according to the dysautonomia these patients have, their blood flow is reduced. And we found out in collaboration with Max Planck Institute Erlangen for physics that the erythrocytes, the red blood cells, are stiff and they cannot deliver oxygen easily. That's why we measure very low oxygen levels. And
Can I ask a question here, Beata?
Yeah.
When you say that heparin helps, are you also talking about low molecular weight heparin,
Yes,
or is it
helps
just
also.
on? Yeah.
It helps also. I started with unfractionated because it has more negative binding site and is a larger molecule and does more, is stronger. But for practical use for many patients, low molecular heparin helps a lot. Yes, to give it to people. You have to consider the possible contraindications, but HIT is a rare contraindication. And if you do it for 1 or 2 months, you do not risk that people develop osteoporosis. So, and in this extracorporeal setting, you do not make leukocytes more aggressive or platelets more aggressive, because there's a shortcut. You give the blood cells with saline back to the patient. And one of the, in nowadays, probably most important effect is that you also remove all cytokines and endo and ectotoxins by more than 90%. And you also reduce C-reactive protein by half. And you combine this with antivirals. I forgot on my therapeutic pyramid, antivirals I use in almost every patient. And there I expect something good for the future, to develop more specific antiviral protease inhibitors. But you can also
can you clarify when you say antivirals? Which antivirals do you mean?
I mostly use valacyclovir. In some patients, I use other antivirals according as to whether what kind of viral other reactivations they have. But you know, the very severe cases have to get long-term antiviral treatment, because with chronification of the disease, the HIV component in the COVID becomes more and more visible. And I see many young patients who have massive lymphocytopenia, who have a Th1 to Th2 shift, and who get sick every week with different kind of opportunistic infections. And those group of patients, we give them also immunoglobulins, and we give them albumin infusions, and we give them glutathione infusions, and we give them NAD+, so trying to restore to restore the glycocalyx as good as we can. And I'm afraid.
Can you address this question here, as Dawn has asked? Is the heparin dose repeated if the symptoms surge?
Well, that's a bit individual, you know. In the beginning, if you start to give triple anticoags, most people get worse. They feel it's like COVID comes back. They are in a battle. And then it gets better. And I got several children out of wheelchair, even without apheresis, by just giving double or triple anticoags together with famotidine. But in the adult cases, the restoration is not so flexible. Yes, but one of the major benefits of this help apheresis relatively specific procedure is that you make the immune system strong again, and then it can fight the rest. Yeah,
Excellent.
much better, and the leukocytes work better and target better. The macrophages work better, and we know this from I've treated heart transplanted patients many times in my time in Munich University, and they had a much longer life duration compared to other people, and it was safe.
And just to bring in Joachim here at this point, this is the very top end of the spectrum of therapy, but most patients will have no access to this kind of techniques, and they are left with using far more practical and simple solutions depending on where they are in the world. Is that where you are targeting your approach, Joachim?
I mean, look, we are you cannot expect with dietary supplements that you can take a patient out of a wheelchair. Yeah, so we have to be realistic. But we are constantly working now on new formulations. We are refining the product cocktails that we provide to the doctors and therapists so that they can use it. We are getting feedback. They say, yes, look at this and look at the spike levels here. Look at this, and it's still a battle. But one thing you can say is this: the senescence, for example, in the endothelium, which is also leading to the. Actually, we didn't talk about the paper much today, but it's okay. It's leading to the capillary death. It's for example senescence. So whenever an antigen gets a SARS-CoV-2 spike or whatever part of the virus or the whole virus gets into a cell, most of these cells turn senescent. So we have seen also with Beate that it helps, for example, during the apheresis. That's how we discovered this whole that you can give the senolytics, and then all of a sudden the filters show much more spike, and you see an elevation in spike levels. So
which image are you talking about, Joachim?
Oh no, this is this is more about the capillary rarefaction now. But to talk about the if you talk about the dietary supplements or regimes that you can use to prevent disease progression into more severe disease with long COVID patients or people that were exposed, then the earlier you start, the better. And that is the reason why this paper here is so important, because if you look at the loss of capillaries, so I don't know if everybody knows what the capillaries are. It's the smallest vessels we have that supply at the end the cells of our organs, heart, brain, inner organs, and everywhere in the organism. So they're the end point of delivery. It's like the transformation box in front of your house where your electric cables come in or the water. And so when they are impaired or blocked, then they die. When they die off, any tissue that is connected with them also dies off. So what we see, for example, we were very, very shocked when we looked at the data of the last 12 months. 2025, from the summer till the summer now, 2026, we had a probably across the board doubling of spike protein measurable in the blood of anybody. Asymptomatic, symptomatic, doesn't matter. 9,200 blood samples with MMD with Bridget. We got the data from 40% spike in exosomes 2025, 2026 first quarter, 88%. And so it goes. So that means if you have a constant presence of spike protein and inflammatory cytokines and other many, let's say, molecules with a high damage potential floating around your blood system and getting to your endothelial cells, the inner lining, then you have what we would call a structural loss. That means the vessels themselves get damaged and break up and die. And then you have the functional loss of, that is what Briat is describing, that you have the blood flow cannot go through the capillaries anymore. You have the junctions, the precapillary sphincters, which are like branches. When from a tree trunk a branch goes to the side, when these sphincters are contracting, which they do through spike protein, so the blood flow is cut off. So these two factors, the functional and the structural damage to the capillary system that provides oxygen, nutrition, and takes out garbage from the cells, if that is cut off, the cells will die. And now it depends on what kind of organ type and cell type you're looking at. If you're looking at the crown jewels, like brain cells, neurons, or the myocardium or cardiomyocytes, then of course that will be practically an irreversible loss. Once the fibrosis has started, not even, I don't think that even stem cell treatment could reverse that.
And I think that when I'm getting people to understand that there is a spectrum of disease, and what Beata is seeing is at the very extreme spectrum,
Yes,
who needs something like help apheresis. But as we said, that's a tiny fraction of patients. But you have a huge mass of patients who don't even realize that they have microclotting, are suffering with symptoms, don't even connect it at all to spike protein. They just think they're getting old. And one of the things that one of the cohorts who is most affected and most underdiagnosed are the elderly cohorts who are already fatigued, who are already got chronic issues, who now on top of it have microclotting. They can't do anything. And people just can't understand why they will shift from being an independent 80-year-old to suddenly being housebound and bedbound. And I've got here this image for the outcomes, Beata. So I wanted you to tell us a bit more about this and explain what you think needs to happen here. This is the before and after help apheresis.
Yes, that is an example of a violinist from Frankfurt, Germany, who had a perimyocarditis and heart inflammation according to her COVID disease twice, once after COVID infection and second time, which after vaccination, she had a relapse. And what you see, the whitish stuff in the big yellow filter here, that's all fibrin you see. And we measured her fibrinogen concentration, and it was far elevated, which has a large impact on viscosity and on the blood flow in the microcirculation. So it's a massive increase. And accordingly, her venous oxygen saturation was only 16.5% instead of 70. 2 hours later, her oxygen concentration was at 86.1. So she increased her fibrinogen and its melting products went down. Her CRP dramatically dropped. Cells were unchanged. So, but she needed, in fact, this lady needed, I think, 14 or 18 apheresis to completely overcome her perimyocarditis. So it was very costly. And I gave her on top colchicine and all what we do in cardiology for treating myocarditis. But I want to give you another example. My own mother last summer developed within one night 4 completely black toes within one night. She never had any thrombotic complication before in her entire life. And I could save her from amputation by giving her the 2 to 3 help apheresis. We could reverse it. But let me come back to your first point. And Philip, I share this with you. I'm very frustrated that I cannot scale up apheresis to every country in the world. But the use of heparin should be available in the entire world, as is the use of baby aspirin available around the whole world. And especially in the winter season, or when it gets colder, then we see this raise in complications. And this knowledge should be addressed in larger trials than I can do. Yes, you know, I ask the big companies to whether they are willing to finance a study from foundations or what, but they didn't do it. And even by giving heparin alone, you will improve a lot.
Yeah. And Joachim, I want you to take a moment, as you said, with regards to the paper, to just explain a little bit about this slide with regards to what is going on the point that you're trying to put across from this image. It is very complicated. So try and see if you can make it simple for a lay audience.
Yes. So what you see on the left middle side there is the structural rarefaction. That's what I mentioned before. So imagine like a pipe system. You can destroy the pipes themselves, or you can clog the flow. Yeah. So the functional rarefaction on the right is clogging the flow, and there's many factors. All these factors initially are all triggered by the direct presence of spike protein, and then the subsequent inflammation, subsequent presence of different cytokines, MMP9, macrophage activation, ferroptosis, mitochondrial dysfunction, and so on. So the whole orchestra of damage is playing also in these very small capillary vascular cells. And the clogging, as Beate described, can be done because of the platelet activation. It can come from the fibrin amyloid microclotting. It can come from netosis, which is mixing with them. And it comes through the lack of the deformability of the red blood cells. You know, the capillaries have a diameter of 5 micron, and that's about the size of the red blood cells. And like our colleague Martin Crater from that we had in our first long COVID conference with his colleagues discovered, they need to be flexible to pass through the capillaries. So when they lose when they start to become rigid, and also the entrance at the sphincters are narrowed, and S1 also, when S1 subunit of spike just gets near the capillaries, they contract. So you have everything possible. So anything negative that can happen in the presence of spike protein, subsequent microthrombi circulation is happening in many patients. So that's the beginning of all the other problems. And that is why these patients one day, many of them might end up at Beate's clinic. And so we see a development. It doesn't, not very often you were in the wheelchair on day one. Some of the vaccinated, yes, they had a big problem. But long COVID is not coming overnight. It usually takes weeks and months to really manifest. And Beate always says, please, Joachim, see that we can catch the patients earlier so they don't have to come to my clinic. Because it's easier to stop disease progression than to reverse some damage. And if the capillaries are lost, these tissues are gone and very difficult, if not impossible, to restore.
Yeah, this is the difficulty, is that I think that from a psychological point of view, the world wants to move on. They are tired of COVID. They are irritated even by the term long COVID. Even in the title, I don't use long COVID, I use post-COVID, because I know the word long COVID will irritate so much of the audience because they just, put it in a box. What people are not realizing is just how much damage is occurring cumulatively. Year after year, we are seeing more and more damage. And my analogy here is to do with hypertension. Before we understood that it was a disease, they were just watching it. And this is why it was called essential hypertension. And
Yes.
if you could, yes, we thought it was essential. And so, in effect, if you could go back in time, even if you found somebody who had not been treated for 10 years and you put them on antihypertensives, the heart damage, the kidney damage, the eye damage, the brain damage would already be done and would be irreversible. And so we are in a situation now where this kind of pathology is occurring year on year. Some people get very unwell with it. Some people may die. But what we're seeing is cumulative long-term damage because, as you pointed out, once some of these capillaries are destroyed, you can't remake them. And so you have tissue which has lost functional reserve, which will only present sometimes a decade down the line. And any thoughts on that?
Yes, today I talked to one of our best stem cell researchers. We now have reached a stage where we also see a rise in aneurysms. We see hernias much more than before, without any reason. Yeah, normally the craftsmen who have lifted heavy boxes get hernias, but you see it in people who had no history like that, and we have a problems in how to restore elastic tissue, because normally our stem cells stop this when we have overcome our pubertal ages. So there are many, many topics that are still largely unsolved, and we will need combination approach, no doubt about, yes. But I think the most important message is that that this kind of gain of function has to be stopped for the world. Otherwise, we are really in trouble, because we haven't touched today the impact it has on our genital systems. We have now in Europe a regression of births by 30%, and this will happen all around the world. Yes, and
Yeah.
this is an inherited, has become an inherited disease, and the companies who made the vaccines made DNA. There's DNA in it. There's RNA in it. There are lipid nanoparticles, each of which can do a lot of harm into it's a central attack on life. And I cannot I cannot think how people can be so stupid to continue this. But our governmental authorities in the European Union still recommend to vaccinate everybody, and even any mammalian, with this approach. It has to be stopped immediately.
Now, there's something you just said there a while ago, Beata, that made perfect sense. When I was looking at the hospital episode statistics, I was doing some analysis on it, and one of the things that jumped out as rising quite significantly was post-surgical wound dehiscence, breakdown of wounds, wound infections, and as you said that, I suddenly realized that if you do have microclotting occurring post-surgically, all of the complications that can happen will continue to rise. And as I said, I know it's being seen. It's no longer anecdotal because I've found the statistics. But why is the clinical community so silent about all these things that clearly are happening Nobody knows. Any thoughts, Joachim?
Yeah, because everybody's tired. I can understand. Look, and it was let's say, the next to the gain of function, there was a considerable psychological operation from day one of the pandemic. So when from January 2020 till March 2020, we were called conspiracy theorists because we were warning of that virus, and we were starting already to prepare here. We went into voluntary lockdown, all my friends, and we bought stuff. We even had masks and everything, and everybody said, "You are crazy." 3 months later, everything shifted completely. So the first 2 or 3 months, they wanted just to let the virus in. Yeah, so that the virus really makes sure it spreads, that it sticks. And once they had achieved that, then they started to panic. And then they overdid it, PCR testing, CT values, etc. And the whole panic, and then the pressure, stopping any kind of treatment. What Beate was, for example, seeing that she couldn't use HELP apheresis for acute COVID, that was part of the program. Stop anything that could treat this virus. You've seen with Shankara, you've seen with Piacori, you've seen with them all, any kind of treatment, hydroxychloroquine, ivermectin, be it what it be, vitamin D, everything was stopped to make this vaccine the only option. And once the vaccine was over, then all of a sudden Omicron appeared, remember? The vaccination campaign ended in 2021, and then all of a sudden Omicron comes. And what did I tell you there? At exactly that time, in the end of 2021, I said, be careful. Omicron is not a joke. It just has lost its allergenic property, that what Shankara was treating, that was getting the severe reactions. Everything else from gain of function is still in Omicron and hasn't gone away. And actually, the pandemic has never ended, and nobody wants to hear that. I understand that. Now, neither the opposition nor mainstream. So we will have to keep on working, even in lack of getting any money back or having any benefits of it, just for the sake of building more progress and getting all these solutions out in place for the moment that the medical community and fraternity understands what's going on. If they have to understand one day, because too many people will get sick. If we would see a decline in numbers of chronic illnesses, I would be the first one to be happy dancing here on the table and tell you, Philip, it's getting better, but it's not. It's getting worse every month still
You know
after
what's
6 months.
interesting is that as you said that, I remember waking up this morning and seeing in the news that death rates in the USA are the lowest they had ever been. Okay. And I remember thinking to myself, how in the world, with everything going on, is that possible? So I dug into it. I'll do a presentation on it soon. And in effect, what has caused that is that drug overdose deaths has dropped by 14%. But every other chronic illness is continuing to rise in 2025. Nobody wants to talk about this. Everybody wants to move on. So as we close out now, I want to hear from Beata and then Joachim. I want you to say what you think you would want to happen in an ideal world, where if you had the ear of someone who was able to make a difference, what would you be telling them to do to help to manage the longer term consequences of this situation?
Work together all over, all nations, make peace, stop wars, concentrate on saving the people of this world on all continents, make easy, achievable, affordable pathways. I think the one clue are the family doctors. In the beginning of the pandemics, they were the general practitioners. They were kept out in Germany. They were not allowed to vaccinate. Instead, they made anonymized vaccine centers. And if you ask the mathematicians and statisticians, most of the trouble comes about from the vaccination, because they were lying in the beginning and over exaggerating the numbers. So what we have to do is to stop the damage. We cannot reverse it entirely, but we have to stop it for almost, especially for the youth, of this world.
Excellent. And Joachim, any thoughts?
We are in a complete conundrum, yeah. That means, how do you want to stop the spreading of Omicron? We see the numbers, the wastewater numbers now. Luckily, at the moment, it's very low. Finally, after we had this immense surge in the end of 2025 and beginning of 2026, and so it's also a cumulative process. I mean, on average, people in the Western world have been infected minimum 3 times across the board, and anybody, vaccinated, non-vaccinated, doesn't matter. And so every time, if we see now the spike protein, we're trying to identify the variants, but it seems to be like, for example, 6 to 8 months, it's still productive being pumped out for that amount of time from the virus, not from the vaccine. And that spike protein is as bad as it is from the vaccine. There's no difference much. We have published on that also. You've seen it. So if that keeps continuously going on for the next few years, we don't need another pandemic. That's going to be enough, not to kill everybody, but to affect at least 10 to 15% of the general population at the minimum, if not more.
Much more.
So that, yeah,
Much
but
more.
I'm very
I see
conservative.
it in the bone marrow. I see it in the stem cells of the people. I see it on the thrombocytes. I see it on the endothelium. It just has to be stopped.
Yeah, but how?
Yeah.
Yeah, no, look, so what are we going to do? We put coffee filters on our nose and lock ourselves in? Do we have good antivirals? No. Is anybody talking about it, creating awareness on television, in the newspapers, in the mainstream media? And the alternative circles, they want to crucify me because I'm talking about the virus. They say, no, it's only the vaccine. The virus is harmless, which is not the case. It's completely wrong. The virus is, especially if the spike protein is produced for another 6 months, which we are the only ones in the world have data. Everybody talks without data. We have 9,236 blood samples, of
Yes,
which
and I have
80% were positive.
cases of patients who are 6 and
Yeah.
6 years. Yes, and
Exactly.
still have spike proteins
So what can
in
we
their
do?
bone marrow.
Yeah. But Beate, what can you do? How can you stop this? It is now so infectious. Omicron's main feature is that it is 15 times more infectious than all the pre-Omicron
Yes, of course,
variants.
I know. You know,
So
we can
needs to
only
be
concentrate all our efforts to make the best of it.
nasal sprays. You need to protect. Yeah.
Yes.
So you need nasal sprays
Of course.
especially when you go to crowded areas, you
Yeah.
go into a plane, you go into a clinic. You guys
Yeah.
as doctors, I told you 4 years ago, you are the most endangered species. If we do spike testing, all of you guys are completely full with spike. Yeah, so
Maybe this is why AI is coming.
I take my special remedy.
have you
It has
wait,
helped me.
look, Beate, have you heard Peter McCullough? There's one group of people that don't get long COVID, and I can hardly say that. It's the smokers.
Yes, of course.
We know the
Yeah.
mechanism, and I'm not encouraging anybody to smoke, so don't necessarily follow.
Well, I think the old Indians in America were not stupid people with their
It's okay.
pipes with for making peace. Maybe the world should remind that.
So
but to finish-
excellent, guys. I mean, we have quite a few people with us. I put the chat on so people can see some of the things that are going on. So just to say to the audience that we appreciate you being with us, and we appreciate the fact that this word has to get out. For those people who know about what I talk about, I keep explaining to people there's like 90 to 95% suppression with regards to people being able to see these kinds of conversations. So there is no awareness in the public. There is no awareness in the clinical community. There is just a hope that things will move on. And I think that's the most dangerous place at the moment, because where we are at this point, based on the trajectory, based on everything that is happening, based on the science, we have already lost 4 to 5 years of damage. And I suspect that no matter what we do now, the best we can do is mitigate the damage we can't reverse it. And that's a reality that the clinical and scientific community will have to get their heads around as well. So appreciate you both. The link to the preprint paper is in the description. And I'm sure, hopefully, we can reduce the amount of people who need to go to you, Beata, because that's probably the best, one of the better solutions. So thank you all for being with us. Just stay with me while we do the outro, and have a great evening.
Goodbye. Thank you.
Goodbye. Thank you.